I was one of those individuals that always cared about other people and wanted to help others.
You're spending more time to actually take care of the patient so that they can be out of the hospital systems.
You see these same patients come in
Mhm.
and out of the hospital again and again. And you develop those, hey, listen, I got to see these 16 patients and start my notes and be done by noon. And then we're going to start to see admissions come in, and I got to get on top of those admissions. A very busy neurologist took that time, sat down next to the bed and listened. And listened to the point where they realized that maybe I wasn't bringing up like things that were, from google.com. It led to that neurologist to perform a test which diagnosed the issue and really changed my mom's overall prognosis and path. And that interaction I will never forget for the rest of my life.
Welcome to the show, Dr. Benish Aqil. Thank you for joining us today. And the show, we would want to explore conversations surrounding compassion, the yeses, the nos, the wins and the challenges that we have with an intention to grow ourselves and also try and bring back compassion to the center of healthcare systems again. Thank you. Thank you for taking time and joining us today.
But thank you for having me.
Our pleasure. To start off, can you tell us a little bit more about yourself and what do you do and how did you get there?
You mean career wise? So I am currently a hospitalist. I did training. I actually went to a Caribbean medical school and then did training in family medicine at Ohio State and
Mhm.
started my career as a hospitalist after that. Went back for training for palliative medicine and hospice. And from there, continued to work as a hospitalist, but also currently am a medical director for a value based company.
Awesome. Uh, can you elaborate a little more about why you chose medicine and what made you go to medicine and then move
Yeah.
on to palliative care?
So I think that medicine for me was something that was natural. I was one of those individuals that always cared about other people and wanted to help others. It was just one of those tracks that I knew I was going to be helping somebody or someone as my career in the future. But I would like to say that it was shaped by my parents and the fact that we were immigrants to this country. My parents came here with not much. They started from scratch here. We were from a working class family and they had the dream. They had the dream of educating their children and getting them to a certain, I guess you can say, position in life where um, where they could live, the normal, not not. I don't know what to say. They just wanted me to become to a certain level and become a doctor, and I wasn't against it. It was just that's the way they want that. I wanted it too. They wanted it, so we started that path. And then I think every experience I've had in life sort of led me to continue that pathway. As a child, I had a little brother who died from complications from a diaphragmatic hernia at a very young age. So seeing that and seeing my parents having to deal with the loss of a child and then going from there, just every little thing that you can see and come across points you towards a path in your life. And I think that's really what led me there. Illnesses with my parents, having to deal with like the medical system and language barriers. And then after medical school, being a physician, I think I was shaped by probably many of my patients that came in contact with me and the interactions I had with them, and also behind the scenes, some of the personal life experiences that you gain as you get older and just continue on with life. I think that's what really shaped me going into medicine. And then as far as the hospice and palliative care,
Mhm.
I discovered that as I was starting my career as being a hospitalist, a lot of my patients didn't have those discussions earlier on. And I found myself taking the time and actually spending it with these patients and their families, having those hour-long conversations. And I know that sounds like, it's not a lot, the hour long, but when you have a day for a hospitalist, a 12-hour day, an hour with one patient's family is a lot. But it's something that was needed. It was something that was needed for the best outcome for the patients. And I really saw these families really take that information and take those conversations and make some decisions that were ultimately best for the patient. And I think that led me towards going into fellowship. And then my personal experience with my family members also led me to that pathway. And I really saw the benefits of palliative medicine and of hospice through that, leading me there.
Being the heart of the show is compassion. When I say compassion, what comes to your mind? And can you elaborate? I already sensed that you've been a caring person all along, and I know that firsthand too. But if you say compassion, what comes to your mind? And we'll explore more about the hospitalist role and the challenges and how the day looks like for hospitalists.
So I often think about that. I know we've had conversations about compassion. Compassion is so much. It's not just like having a heart, I think, and feeling for others. I think it requires so much more. It requires and it changes. The type of compassion you may have as an individual changes with each experience that really does make an impact on you. So for me, like my compassion as a child was probably different than it is now. As a child, I was always one of those feeling people, like would feel for the, sad, if there was something sad going on, would feel happy or would like to help others. But then it brought more meaning to it with each experience in life and with, and now into my adulthood, I think my compassion's a little bit different. It requires so much. It does require you to have time. I mean, with patients, with yourself, with every interaction you have in life. I think it requires some time, and that's one thing that as adults we don't allow ourselves to have always. And it requires you to step back and take some time to really to get to know people, get to understand the situations that other people are in or what situations happening around you. It's not even about other people, it's you yourself and understanding how you feel during it, and then really observing others and seeing how they may feel or their reactions, what they are like in those situations. Compassion is so much. It's not just your feeling, it's touch, it's listening. It's hard to even describe how, at least for me, what I find compassion to be. But I do think that it has a lot of power that we don't think about, and especially in healing and also just in humanity. I think for those individuals I find that I have a little bit more compassion than maybe somebody else, they tend to have better ability to nurture relationships, to develop themselves in a variety of different situations than someone who may not have as much compassion.
Yeah, that actually makes me want to bring about something that I've read. As I was looking into compassion, I was looking a lot into the evidence, and there is a lot of evidence out there that basically a compassionate approach has better patient outcomes, and that's not just a nice thing to have, but actually a smart thing to have. So over the years, you said like as a child it was different, and now as an adult you feel it's different. But have you changed from the earlier years of your career to now in terms of?
Definitely, most definitely. Yeah. Most definitely. I think I became more compassionate, if not. I think early on in my career, you go in, you have a heart, you're like, "Oh, I want to help people." And then sometimes in your career, you have times where it's like, "Oh, you're just so busy and you're not." And there were times I would say that I didn't have the time to listen. But then I you realize, like, when you step away, that, oh man, maybe that patient better would have had a better outcome if I like sat there and spent that time. I think a big component that I discovered over time was time is required sometimes for compassion, especially with patient interactions. But I think that as my career came along and I started to realize that, and I spent that extra time with patients, and I had those conversations with patients, that each of them, at least the ones that I felt were very impactful to me and personally, made me change the way I provide care to other patients. Like it made me realize, like, listen, that worked for this family, this worked for this patient. Maybe it'll work with someone else. Or Benish, like you have to be more cognizant of like the condition that this patient is in. Personal experiences also affected me. When I came and started my career as a hospitalist, my family was in a different state. My parents were healthy. I didn't have to worry about that kind of stuff before. And then as the years started to go by, I started to notice different things, and the disease processes that they had, I understood better and was able to bring that into my job. Like, for example, aging and dementia and end of life for patients like that. That made me more compassionate for that population of patients. And I could identify myself in families and patients that had to deal with it and was able to utilize, or I felt that I almost had more heart in those interactions and wanted to spend more time with those patients.
Thank you. So I said you're a hospitalist as well. Like, can you elaborate on how a day-to-day work looks like for hospitalists?
So it varies. Right now, like I work at a night shift, so I'm a nocturnist, mainly doing admissions. Or when I first started my career, I was doing daytime hospitalist work. So, you start your day off, you're tired from your night before with your, families. You come in, it starts very early, starts at 7 a.m. and you have sometimes a heavy list of patients to start off with, and sometimes it's a little bit less, but usually around 16 patients, I would say, is like the average, 15 to 16. And throughout the day, you're seeing those patients, getting to know them, getting to know if they've been in the hospital, what's kept them here, what are their barriers to becoming healthy and leaving the hospital, or what are the things that they're facing still going forth in their hospitalization. And then we also have, like, admissions I do in the and during the day. And during those times, that's actually my first introduction with patients and families often. And I initially went into hospital medicine thinking that, like, I put a band-aid on the patient to get them better, and then they go home and I may not have to get that continuance of care. But I realized over time that I do get that continuance. You see these same patients come in
Mhm.
and out of the hospital again and again, and you develop those relationships even though you initially weren't thinking that that was possible. So
So with 16 patients in 10 hours, 12 hours, and
twelve, yeah, 10 to 12.
I know earlier you mentioned about the need of time, right? To spend time to exhibit compassion or be compassionate. So, how does that work? And is it easier to be compassionate all the time? What are the challenges that generally the hospitalists face?
So time is definitely a barrier. And I have to say that it's something that you always have to have in the back of your head, that you have to be cognizant that you have to spend some time with patients. And, you know, it's very easy to get into that. Hey, listen, I got to see these 16 pages and start my notes and be done by noon. And then we're going to start to see admissions come in, and I got to get on top of those admissions. And then we have to worry about discharges and stuff like that. And it's very easy to get involved in that and actually not take that time with those patients. My day would usually start off with me reviewing what brought them in and where they're at, and I would go and assess which ones may need me a little bit more. But as the day goes on, you realize things change, and new developments happen, and you may get stuck in a patient's room. And I know that the word stuck sounds bad, and it often is, even in a hospital's eyes, bad, because you're like, that means more time in a patient's room. But it's time that's needed. And that's what I realized as my career came along, is that if I don't spend that time, I'm doing the patient an injustice. I often would get, pages while I'm with these patients having these conversations. Oh, you have an admission waiting for you, or, so and so needs to be discharged, that kind of a thing. Yeah. I That being said, there were many days I wouldn't eat lunch, or you wouldn't even get a chance to go to the bathroom till late in the afternoon, and you didn't realize it. So, like, it just, it did affect me. I felt very, not saying burdened with that load, but like, because I cared to spend time with the patients, you felt tired by the end of the day because you spent so much time with them and tried to get some of that clarity there. You felt tired. You felt that you almost always through a, through a lot because of those conversations. But if I don't do it, who else is going to do it? And then it just, that was in my head, is like, if I don't spend that time, it's, I'm not doing the patient a justice. So yeah.
That's so true. Yeah, I think, but I think there was some important, rather very important point that I felt was that you mentioned is like being cognizant, right?
Hmm.
Giving that time, giving that compassion, giving that listening ear to the patients. And if we don't have that in the back of the mind, and if you're thinking 16 patients, I have to see these patients by noon, or and just follow up with your admissions, then if you're in that intention, I think we don't even think about, right? Think
Yes.
about
Yes.
extending the time. We are just doing our tasks and continuing. And I think so, and we miss out the
100%. I think that that's where it, and I'll tell you a personal experience where I actually realized that that's where medicine originally lies in, and it should be like this. There was a particular time in my life where I believed that a patient had, well, the patient being my mom, she had a medical condition, and I really felt strongly about it, but I felt that no one was listening. And I'm in medicine and nobody was listening, and I was a family, I was on the other side, I was a family member. All they saw was a patient that was very sick and didn't, maybe was not compliant to medication and therapy before, or we could say she was a mess of a patient, which rightfully so, she was a mess at that time. But I had one busy neurologist come in the room, a very busy neurologist. I know the hospital system, and took that time, sat down next to the bed, looked at me, looked at the patient, and listened. And listened to the point where they realized that maybe I wasn't bringing up like things that were, from google.com. It was something that, these were all symptoms that could make sense if they went that route of diagnosis. Anyway, it led to that neurologist to perform a test which diagnosed the issue and really changed my mom's overall prognosis and path that hospitalization could have taken. And that interaction I will never forget for the rest of my life, because after that, I made sure that it doesn't matter who it is, it doesn't matter what condition they come in, doesn't matter what other diagnosis they've had in the past. I'm still going to look at them as a person and still going to try to listen to the family and really develop through that listening a idea for myself without bias, without anything else. But it does require time.
that actually was so powerful, Banish. Being in the hospital system, being a physician yourself, if you have faced a situation where you see that multiple admissions being labeled as non-compliant, right? And that tendency carries over. And how frequently is that happening across the world? Right? How frequently are
Oh,
we labeling people, and how frequently are we not listening, and how
I
frequently
mean,
are
I will have to say, like, it's so easy to get into that. It's so easy to being like saying that anybody is non-compliant, but without pausing and saying, why are they non-compliant? Like, I've done this to other patients, I'm sure of it earlier on in my career, and maybe still it's hard for me to do it, but it's labeling them and then not understanding, you have to pause yourself and be like, why? Why are they? Is it money? Is it that they don't have support at home? Is it they don't understand? Is it a language barrier? Is it cognitive issue? Or are they sad, depressed? So many things play into somebody's health that we don't think about. And then as physicians, it's easy for us to forget that.
You just nailed everything we should be doing with every person we come across or when every patient we come across. But that brings back to the time, right? There is this evidence that I know time is a constant, term that we hear when we talk about compassion or spending more energy or listening, right? There is this evidence saying that basically for one act of compassion, 40 seconds is sufficient. Again, probably for me, I'll go back and say your point of being cognizant and wanting to do that itself, that makes a difference, right? If we don't think about that and not even consider that and just being on this taskmaster nature, then I think we'll completely miss for our whole career. There will also be patients during that whole process or the 24 or the 12-hour shift or 10-hour shift. Some of them would be easier. Is there a possibility to balance? Is there ways that you have explored where we can spend all the time, energy, and be not still feel exhausted or tired at the end of the day? Because we also need to replenish ourselves, take care of ourselves to be able to take care of others. So have you ever explored into all those possibilities?
Yeah, I think that you have to, especially when you get a panel of patients that you have to see every day. Some of them are easy. Or not saying necessarily easier, less complicated. They're, everybody's, has, if they're in the hospital, they have something going on, but there's some are less complicated. So those patients would require me to have less time needed or a less in-depth conversation, pretty much like just update them on how they're doing and, or if they're being discharged and what the plan of care was. But that did allow me to spend a heavy part of time with those patients that needed more conversation. It can be affected on how many sick patients you have. That's a different factor. But if you have a good balanced list where you have some patients that require less and others that require more, then it's a great balance that way. But like if you have a significant number of patients that are ill and require a lot more care or thought or evaluation than others, it can make the day be a little bit more heavy. I will have to say, as hospitalists, like there were days that were really heavy and then there were days that weren't. So that would those days that weren't would balance out those other days majority of the time. I mean, there were times that we've been through COVID, we've been through so many other factors in our life that during that time it felt like everybody was heavy. There were a lot of those conversations that needed to be had and in very difficult circumstances. So that those were just a particular time, but majority of the time before that and after that, you usually have a balanced or can have a balanced list. If there is a day that's really bad, sometimes the support of others on your team is necessary. Luckily, I work with great colleagues. I could reach out to someone and say, listen, I have a really sick patient. Do you mind just doing this admission and I'll make it up for you with you later? Like I'll do one of yours tomorrow or something like that. And most of the time, my colleagues would come to my rescue with that. So it does make a big impact on when you have a good team along with you working.
That's great. So yeah, also it makes me think that remembering that balance, right? Sometimes we will have heavier days, and on those heavier days, if we can think about the days light, light at the end of the tunnel, it'll probably give us a little energy boost, hopefully. Going on to back onto the point of the neurologist, right? And you said you emphasized on the word sitting and made eye contact and listened to me. Has that practice or changed the way you sit down, and how frequently do you sit down, and have you noticed a difference that will bring sitting down with your
So
patients?
I think personally, uh, I've always been a little bit more touchy feely slash like a person that likes to get really close to my patients in terms of like I've always been one that would sit a majority of the time in the room unless like the patient's got like a flu or something weird like that. But Otherwise, most of the time I will sit there and try to listen to them and talk to them like that, not like I'm they're, trying to be a larger figure for them, but being on their level and trying to get a really good idea of what's happening. It just made it more cemented when I saw what that physician did. And the fact that the demeanor was so much more the body language, the demeanor of understanding and really saying, I hear you. I think that those words really make such a big impact on I hear you, I understand. Or if somebody's saying like, especially with a non-compliant patient, you're worried they may be saying, I did take my medications or whatever it is, but you stopping and saying like, listen, you can tell me really what's happening. Tell me, share to me what makes it harder. Share to me what brought you in today, or share with me how you feel right now. Some of those open-ended questions make it so much more easy for the patients to share things with you. Sometimes they'll share too much, but most of the time they'll share the things that you really need to listen to be able to help them the best that they can be helped. And that particular interaction, like I said, has impacted me to the point where I really do sit by my patients now. I do try to make them understand that I'm here for them and I am listening. I'm not judging, I'm listening. Or technology makes it a little bit more difficult now. Like, you're trying to type in the room and you're trying to do the medication reconciliation and stuff like that. For me personally, like I'm one of those old school, like I'll write it down, which makes and be sitting there without the computer. It may slows me down a tiny bit, but it does allow me to get more from the patient. At least that's what I feel.
That is very powerful. And it seems like there is significant evidence that even sitting down with our patients makes a significant difference. And even in the perception itself, like though we think it's actually takes longer, it's perceived that it's still the same time, but actually it's perceived as much longer. And sitting at their eye level makes a huge difference. That's also powerful. So if we can switch the gears a little bit and talk about your medical director role, right, of the
hmm
Value Care Center you were talking about. Tell us a little more about how the day-to-day works there and what are your responsibilities.
So the my interest in that peaked really about the culture that they have going on in terms of having patients receive the time that they need. So the difference is that these patients are getting an hour and a half, whatever they need to have them understand their chronic condition. So initially, my company started off as a kidney company, where the patients were CKD or chronic kidney disease patients with advanced disease like stage 3, 4, and pending end stage. So they really trying to help them understand what their disease process is, how to minimize it getting worse, and what other factors played into it. And then also helping them understand what are your decisions that you may need to make in the future, whether it is like, do you actually want renal replacement therapy, or do you want to think about, just taking care of yourself the best that you can, the tightest control of all of your other comorbidities, till you ultimately start to get symptomatic and then maybe consider changing gears towards more of a palliative / hospice route. Over time, like, the company discovered that, like, or not discovered, understood that weren't just taking care of kidney patients, we were taking care of heart failure, high blood pressure, diabetes, that all played a part into those kidneys getting sick. That being said, the best part I think of my job is that um, I get to spend time with these patients. And the advanced practitioners that I work with, they are also spending time with these patients. So the outcomes may not be what I may want for a patient, but they are outcomes that the patient understands or has received extensive discussion about, and it's their decision. And usually those are, the decisions that are the best type of decisions for them. The ones that they are educated 100% on. They know what they're going to face, their families know what the patients are facing, and then they can go on. I like having the time with to have these conversations because they're not easy. And also understanding that there are other providers may not have that time. So we've had taken care of so many patients through this job where they're like, listen, we really love the extra attention you give us because my primary care provider doesn't have the time. And it's not the primary care provider's problem. It's just overall healthcare as it is now. In a setting like a hospital or a big a network, they're being regulated on how many patients they see, productivity, productivity, productivity. In my type of a job, it's more outcomes. We're looking at the value we bring to these patients, the outcomes that they have, and really keeping them as healthy as possible, and in their own home setting rather than them being constantly hospitalized or having uncontrolled, medical issues. And then for those patients that are very ill, or as they progress in their illness process, having those discussions about like, listen, ultimately, earlier on in your life, would you want certain things done for you now? Like, would you want to be going to the hospital for the 10th time this year, or would you want to be on dialysis? Having those conversations, having them have that conversations with their family so they understand, and actually getting it in writing and actually helping other physicians or other players in their health care get a better idea. It really is a fulfilling career. And I love my patients. I love the outcomes that they get. We've kept so many patients outside of the hospital after being hospitalized multiple times for like heart failure throughout the year. They understand their disease better. They understand like why they're on certain medications. They understand what to eat, what not to eat. Like just and then also hearing them like, listen, I guess hearing what their barriers are makes them feel heard, makes them feel better, and then wants them to take care of themselves more. So it's like a compound effect. So I think that just spending that extra time that this job allows me to do, um, eh, really is what I needed because I wanted my patients to get that, and I think it's ultimately what the patients need too. So yeah.
So it's very interesting to hear this type of job, and because everywhere the pressing aspect is time, right? As you said, see more patients, be productive, see more patients, right? That's constantly there. And at least the understanding is that as we see more patients, if we think we can bill more and if there is more revenue generated. But I'm seeing this as an opposite way, like you're spending more time to actually take care of the patient so that they can be out of the hospital systems, right? And
Exactly.
so, how, and still, this company should have to be financially viable and they should be paid, and everybody needs to live their livings. How is that? Can you give a little more insight into these two extreme aspects? And I feel that
So
probably.
yeah, so a lot of these value-based companies are basically runoffs or connected in some way to our larger insurance companies. So, the company that I work with is contracted with these big insurance companies. And ultimately, insurance companies want to save money. It's money driven from the insurance companies to join us because the more better outcomes we have for patients, we're saving dollars for these insurance companies. And these dollars aren't like it's a little bit of dollars, they're into like hundred thousands, millions of dollars of savings, ultimately, the more patients that are helped. So, what the company gets is through their contract, a certain percent of the savings gets given to the company. So that's how the company makes money. But ultimately, who gets the best care is the patients in that manner. Like we're saving the insurance company money, but the patient is getting the care that they ultimately need anyway.
And that's what is the ultimate, right? We are into this profession to give the best care that we can. And when we think that this model is actually helping insurance companies to keep that money or save that money, then that's entirely okay. But why are we not doing this everywhere? Why is primary care being pushed into see these number of patients, and how is that can we envision there a value-based model too? I know there is a lot of talk about value-based models.
Yeah. So like where I trained in family medicine, it was considered like a patient-centered medical home, a PCMH model, which was brought in value-based a lot. So they had value-based criteria of what they wanted goals for their patients. Well, I think that ultimately, like having that requires a lot of support or support aspects. So it requires strong social work help. It requires sometimes subspecialties to be right there to help in terms of managing these patients. Larger systems, I think, that can have that support within their model can do it very easier. I think smaller systems or private practices may not have that ability to do that, although it's the best for the patient because in that setting, the more patients you see, the better. Otherwise, the income won't be there. But in these larger systems where they have all those support services in place already, I think that it's a model that's pretty effective and works for people. I know that even within our system, that we do try to look and see for readmission rates, like looking at CHF and COPD and trying to avoid readmissions. But that doesn't stop. That really isn't, I would say, only a hospitalist issue. It's something that requires a lot more support. It requires our pharmacists to look and see, are they on optimal medications when they're discharged? It requires somebody to go out to the home and make sure that the patients actually got those medications and are they using them appropriately. It requires the communication to be open and the patient to know that they're able to call someone and be able to get through to them. And in that state, then we can prevent hospitalizations for patients if they're able to get in through to them. But nowadays, because the practices are so busy, patients aren't able to talk to their doctor the same day. They're able to leave a message and they're told call you back within 24 hours or 48 hours. And by then they're in the ER already or they're admitted already to the hospital. So like there's so much other playing factors that if we look at them carefully, I think it's a good model that can be adopted throughout large systems, but it requires those supports to be there and time for us to develop that, I think.
All right. Yeah. So going back to, I know we talked a little bit about, you mentioned a little bit about readmissions, right?
Mm-hmm.
I want to bring back that point of compassion and listening and playing our role and how it can affect readmissions and length of stay, because I know as hospital systems generally big on those two aspects, right? Length of stay and readmissions.
Mm-hmm.
Do you think a task-based approach, right? Do this, do this, do this, be productive versus the compassionate approach where you can sit and listen and give that extra minute or so for more complex and complicated situations? Will that make a difference? And is that um, feasible approach? And how can we bring that into our hospitalist models?
So I think that for certain patient populations or certain disease processes, yes. Chronic pain, I think that would be very difficult sometimes to do that for. But I think for like our patients that are COPD, CHF, cancer patients, a lot of these type of disease processes, if we spend the extra 10, 15 minutes, I think especially on discharge days, going over their documents, going over the recommendations rather than just having it typed up and in a form or a discharge summary given to them. I think it makes a huge impact. At least for me, when I would actually pick up the AVS from the nurse's desk and go to discharge a patient, I would go over the instructions with them. And I think that allows a patient to hear it, what they have to do, and then when you ask them, listen, now you tell me what I just said. Tell me what I'm telling you to do when you get home. Or tell me what things you have to look out for. And when they have to repeat it back to you, they can confirm that this is something that they heard, that they understand, and that they're going to listen to. And actually saying like, maybe reaffirming that they can, especially for patients that come into the hospital frequently, you can encourage them, like, listen, as soon as you start to feel unwell, or as soon as you start to see like you've gained a pound, call your primary care, call the cardiologist, or call your pulmonologist and try to get instructions for them. We do now provide instructions to our patients, at least for CHF and a lot of patients for COPD, even in the hospital, that like if their heart failure, if they start to gain weight, like just double up your Lasix, and then also call your cardiologist in hopes that that fluid comes down and their weight comes down. But I think that just reconfirming that they understand instructions, understanding like that they have to go pick something up from the pharmacy, or they need to get it delivered, and what things to look out for really helps patients a lot. Time, that being said, I do think that 10-15 minutes is hard, especially if you have like 7 discharges in a day. That would come into like over an hour and a half spent with patients just for discharges, talking to them. Overall, as a hospital system, you may see you likely will see less readmissions within a 90-day period, I think, for that
I
population
mean,
or
that
subset.
it makes me think that 10 to 15 minutes. Yes. If it's 6 patients, yeah, it's an 1.5 hour extra. But it's a readmission costs how much? I don't know. Right. So those are
Thousands, yeah.
those are hundreds of thousands of dollars that we are able to save, right? But I think there
Yep.
is also this push on like see no more number of patients. So if we are seeing more number of patients, like 18 patients, I don't think it's safe. And I don't think that's feasible to and spend the time. So it's like it's that double-edged sword, right? You're trying
Yep.
to see more patients, but what we really need is educate and take time to prevent that readmissions. But being asked to see more patients and also prevent the readmissions, right? So
Yep.
that's so or like redundant. And if we just give the time, we can probably save hundreds of thousands of dollars. Going back to the length of stay. Sorry, did you want?
The one thing that I have noticed is like, even in hospitals and in private or like regular health networks with the doctor's offices, a lot of the times that the education that doctors used to provide for patients, and I'm not sure, this is just my personal opinion whether it's true or not, is the doctors used to provide the education. Now, as time has gone on, years have gone, that education is now provided by others. The question I often think about is, are those individuals providing adequate education? I know that they have abilities to do that, but like really supervising or monitoring them, or making sure that there is like a uniform way that that education is provided, may help, especially as we start to offset some of these responsibilities to other people. But going back to it, if in those settings where the doctor was giving the instructions and the recommendations, do the patients listen more, or does it hit home more to those patients, leading them to get better? I'm not sure.
Got it. So I think I want to bring that point of what we were discussing recently and how just listening to them and your medical director role. You said that you've noticed people just want to be listened to, right? And just that
Mhm.
listening makes a huge difference, even in hospital
Good. Yep.
admissions. Can you just elaborate on that for us?
So I've run into like over the years I've worked with this company, I have several patients that you could say are your regular patients. Like they're the ones that they have nobody at home, maybe, or they have somebody, but it's they're children that are working long hours. It's just the way society is now. But the patients themselves are alone, and they're scared because like they have like underlying medical issues like COPD or heart failure, and the littlest cough or the littlest shortness of breath with walking may make them freak out, or like make them like worried about something going wrong. They just want somebody to give them affirmation that they're okay, or listen to them, or give them advice. So those patients, they know how to get in touch with me, or know how to get in touch with the nurses, and they will call. And sometimes they just want to vent or listen, and you have this 10-15 minute conversation, and then you realize that over 6 months you've kept them out of the hospital when they were going to the hospital literally every 2 weeks before that. And why? Because they knew that they could get in touch with somebody who would listen, who would give them advice and tell them that they'll be okay. Sometimes that's just the affirmation patients need, especially when they're dealing with chronic illness. Chronic illness like really hits people hard. I mean, it's not like a virus or cold or pneumonia even that, after a couple of weeks you'll start to feel better. These chronic illness patients, those are diseases that will likely never go away. They can get controlled, but they will never go away. So they'll have days that they feel really bad. They'll have days that they'll feel really good. Or they just feel days that it's just consistently, one way. And having that extra support, the affirmation, I think is very important. Lucky people are those people that have very supportive families or friend networks that can get that by themselves. But the way our society is now, it's not like that anymore. I mean, I wish it was that was a situation, but the more so that we see it's the opposite. We see a lot more of these patients alone, having to deal with this stuff alone, having to deal with fear alone. And that in of itself is one of the most factors, in my personal opinion, that makes people ill or can make them more sick and get them to the hospital.
As you're actually saying, this thought comes to me that I'm sure this exists, this systems exist, but I'm sure there are support systems that exist for chronic conditions out there. I don't know if they're associated with the primary care systems where you can develop these communities or groups where you can, heart failure group or COPD support group, right? The support groups. I just need to find out. But are you aware of anything like that where the private practices have those support groups and somebody to moderate those fears and concerns?
It's coming. I mean, it because of the fact that our doctor's office are so varied. Some are connected to large systems, some are private practices. There are these support systems that are coming through in the form of these value-based companies. So like my company would link with these insurance companies and provide care to their certain subset of patients. But that requires also understanding from their primary care providers to know that, listen, this company is not going to go and take our patient away from us. They're adding an extra level of care or support. So they need advocacy from their own primary care doctors or their own specialists that, listen, it's okay for you to work with these companies. Sometimes insurance companies have other, within their own, like I know CVS and Aetna have their own subsets of support set in place for patients that they can offer. It's just having that explanation provided to the patients, like, we're not taking away from your health care, we're adding to your overall care, having you be involved in this program. Sometimes patients don't understand that. The smaller groups, the smaller practices will have a hard time because they're often isolated by themselves and they don't have that built-in support, or linkage with things.
Mhm.
So they may be a little bit more isolated. Nowadays, there's also concierge medicine. So just the having that model is a whole different question for me. And I think that as long as that they have a smaller population that they're taking care of, that's great. They get access to their doctor immediately. They get advice, support. I mean, that would be in the ideal situation, but not everybody can afford that. The majority of patients can't afford a concierge model. And I don't think medicine is all going to go over towards the concierge model simply because of cost efficacy, but that probably would be the ideal.
But how about the peer support group, like the COPD peers, so that they can discuss with their peers of the same? And I think if private private primary care systems, if they can have one or two
Like
person,
support groups,
yeah,
like
support groups, but
condition support groups.
yes, condition support groups, but associated with the primary care with one or two moderators. But the peers amongst themselves can also probably discuss, and because especially it's the
Yeah.
fears and right. It's the fears and the concerns with the chronic conditions that you're talking about. I mean, as you were talking, I was thinking,
that would work 100%. But the question is time and logistics of doing it. That's really what it is. It works. Like, I think that in a residency setting where people, like, where you have residents that are wanting to show impact that they can do, I think it's great projects for a lot of these residencies. Hopefully, if they can learn how to larger scale it, I think it's great. Remember back in the day, I did a focus peer support group for diabetes. I had patients that were new onset diabetes, and I had patients that have dealt with diabetes and they're elderly now and with complications. And they learned so much from each other. To this day, I still remember my nice little old lady who told a young man who was like in his 30s, listen, you got to do this. You got to take your medicine because, you don't want to wind up with me like blind and on dialysis. That in of itself was enough for me to say, like, listen, that actually helped the patient understand, like, listen, if this is not going away, this disease is not going away, and to actually take it seriously and take your medications and go to the doctors, because she had all of the complications related to it. So, but she needed to hear other people say, hey, like, you're such a great teacher. And she just wanted to be heard and understood that she's helping other people. So it's such an underutilized idea and opportunity. I wish it was utilized a lot more, because I think 100% it would make an impact. I just don't know how we would do it large scale.
Hope somebody who's listening to this probably will take up and take it forward and make it large scale. We'll see, I think, hopefully. So now in the medical director role, we're coming to close to 57 minutes, but in the medical director role, right, compassion, how do you exhibit compassion and how that makes a difference to yourself and to your colleagues and to your subordinates and to your team?
I think just compassion needs to be present on all levels. Like, at least I try to exhibit compassion even within my own team, because it makes a stronger team when you try to listen and understand each other. There's different things that each of us are going through. If we don't stop to try to understand it for a moment or try to listen, our team won't be as strong. You want to be able to identify if there's something going on within your team, and so they know that you can depend on you as a leader. But then going broader, the compassion that we offer our patients, like, if I'm compassionate and you're with the APPs or the nurses, and they exude that same type of a compassion to others, I think that there are patients that we have to have conversations with a little bit more urgently about things, and they know when to escalate it, and we can do it as a group. Like, them understanding that I'm available for them, we get on a Zoom call together and we take care of the patient immediately right then and there, or have those conversations that may lead the patient to say, listen, I don't want this to happen. I don't want to go to the hospital. Can you figure out hospice for me? Can you figure out, what my next steps are? And us then having to move and get that done for them or work it out for them. That compassion is there on every level. I mean, and then for me, even just to have that happen for patients, I need my social workers to be there and work really quickly and helpfully for those, or even the hospice companies that I call and say, listen, this patient I think qualifies for hospice. Are you able to get out to their home today? Wife is scared. The patient is scared. They need the support. And for them to be able to listen to me and say, like, okay, this doctor is wanting to escalate this. It does seem important. Them hearing what I have to say and then going out to help the patient. It works on multiple levels.
Tell us a little more about the compassion you exhibit for yourself and how do you take care of yourself to keep this going?
Okay, so I think that's probably the weak point, compassion for myself. I think it's something that you have to be much more cognizant of. I think as individuals in the healthcare field, a lot of us are so used to giving compassion to others, to taking care of others, putting others forward in our lives, that we forget that we are also ones that deserve compassion. I'll use an example, and it may seem a little bit odd, but it is, I think for me, it made me realize on so many different levels what compassion can do. So if I remember correctly, it was during COVID, where we're working long hours in the hospital, or it was right after COVID. It was around that time. You know, dealing with large patient loads, dealing with, also home things that were going on in the background. We're people. We take care of others, but we also have things that we're dealing with um, outside of that. And we try to come into the hospitals or into our patient office like with this shield on that we're not human and that we're super powerful and stuff like that. And patients want to see that or want to believe that, but at the same time, we are human. So that this one particular situation, I was, it was a long day. I was probably late afternoon, and I remember I was typing up notes and working on orders or discharging something or not like that. But I was in the computer sitting at like the nurse's desk area. And by chance, I think it was like nurse's day or around that time. And a cart comes by, and it's these nurses that I've known for years, and they're lovely people. And they're offering hand massages to other nurses and offering like treats off this cart. And I'm just typing and listening and stuff like that. And then all of a sudden, one of the nurses says, "Dr. Aqil, come, give me your hand. I'm going to give you a hand massage." And I was like, "No, no, 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 it's okay. It's okay. I'm fine. I don't want it." And she's like, "No, just take a minute for yourself. Give me your hand." And she took my hand, and then all of a sudden, like a minute into it, like less than a minute, I just started sobbing, just started crying, because I think that was a moment of weakness for me. It was the first time in a long time when someone understood or felt that I may need something, or a moment of compassion towards me. Being a healthcare worker, a doctor, a mother, sister, daughter, every other role that requires care for everyone else, I think in that moment I discovered that I forgot that I'm also a person that was going through things, and being strong with everyone else. That moment made me, I can't say weak, but it gave me what I needed for a minute. It gave me a time to stop. It gave me a time to let it out, whether it was tears. And I know that people think that tears are weakness, at least as in medical school. Maybe that's what not in medical school, I would say, but like in residency, every time I would get tearful, it would look like you're just a female that's too sensitive or whatever. So you try to like, stop it and try to look more harsh or whatever it is. But that those tears, like they were like from God knows where they came, but it gave me a release I needed at that moment. And that small amount of compassion that I received at that moment helped me for days probably. And I felt like a fool from the nurse, and I was like wiping my tears and like, "Oh my God, I'm so sorry. I'm so sorry." And she's like, "No." But for that moment, I needed it. I needed the touch. I needed somebody to say it's okay to me to be able to receive that compassion. And I don't think that as healthcare providers we let it on that we needed it a lot too. Yeah,
Yeah.
we wear a hat, at work for 12 hours as being the doctor. I'm going to take care of you. I'm going to get you better. I'm going to do that. But then we wear different hats when we get home. And those hats may be so many different hats. It all depends on what you're dealing with. Some people may be alone and lonely and dealing with those type of issues. Others of us may be dealing with like being caretakers for elderly parents. Others may be parents and moms and dads and, things that they have to deal with. So it was like that for me was, I guess, what I dealt with compassion for that moment as a physician. But overall, I would say I really don't do well in taking care of myself, and I'll admit it. In terms of outlets, I will have to say my kids are my outlet. In terms of, you forget when you come home and you get that first hug or kiss or whatever before the stress comes on of homework and life, that the first touch that they give you is what my outlet is. Then the homework comes, or what am I wearing the next day, or do my hair, and whatever other stuff that they bring along. But the unconditional love that I get from them is my outlet. I won't let them know that, but that is my outlet. And probably the only outlet I have right now.
And
Or
Dr. Akil.
laughter with my sisters. That's the other one. I call them and we act stupid on the phone, and that's my other outlet.
So I do have to point out, Dr. Akil, that that was somebody showing compassion to you, but my point was, yes, self-compassion, something that probably you should start thinking more about and
I know.
giving those moments. All right. Okay. Sorry. I apologize for my tears. I think you probably held it back. I don't think
Yeah.
tears are weakness. I think they're strength. And I have a completely different opinion on them. But coming back to the 5 rapid fire questions, one word responses. If I say compassion, what is one word we equate that with?
Listening.
Self-compassion.
Hard.
And healing.
Love.
And one book, person, something specific that inspired you the most. It's tough. It's a tough question. If you have more.
Inspired in terms of career
Career,
or life.
compassion. Yeah. Career, compassion, love. But yeah, one book that stands with you or one person that stands with you.
Mom and dad.
One thing that you do every day to keep up the compassion or the caring person you are, or I think.
Take care of others.
All right. As we come to the close, is there anything else that you would want to share with us that we may have missed? I mean, I still have so many, probably will bring you back another time. But is there anything else we should talk further at this time?
No, I think that compassion is just after our conversations, we think about it all the time. It's something that, and we were trying to identify, is this something that can be learned or is it innate? And that I do think I've come to that realization that it's part innate and part can be learned, but learned from others, experiences, and life, and just self-realization and self-reflection. That's what I ultimately think it is now. But again, we're all learning still.
Thank you actually for touching that point. And it's so, so important. Yes, many people would think that it is innate, but it's so true what you said just now. It's not just innate and it can be learned. And these are skills that can be learned and strengthened with practice. And like any other skill. And thank you for bringing that. And there is actually evidence around there as well that it can be learned. So hopefully
I
we
mean, the
can
next time we can also talk about whether religion brings in compassion. I was thinking about that also. So next time we can talk about that.
let's actually go ahead and talk about that.
No, I'm just wondering if that does bring. So like for me, every time, and it may be like a little bit odd, but when I'm taking care of my patients, if I do tell them there's times that they may need prayers, they may need sometimes, and I always mention God, not understanding that maybe not everybody understands God, but I say whoever it is that you believe in or whatever is out there, but you can pray or identify with them to try to be heard. And even now, like when I, for example, have to go pronounce a patient, when I even enter the room, I'm saying the prayers that I would normally do for any loved one I have, because they're in that phase from between life and versus the next life that they have in a different realm. So I still do that. Maybe it's odd, maybe it's not, but whatever. It's for me, it's like more of a respect slash also saying, the compassion that I would give to everyone that would come into me. But I do think that religion can play, or the more you get into a religion, whether it's any religion, it can play a role in compassion, because majority of religions have compassion built into it. I mean, not majority, all of them. I mean, that's a reality. So I do think that also may play a role in people, but like I was saying, everything plays a role in building in life, the interactions you have. Like, for example, my sister's my opposite, and I use my family as examples because I've had them forever. But my sister's my opposite. I would say growing up, she was the headstrong, not compassionate person, you could say, like didn't have feelings, like that kind of a thing. But the experience that she had taking care of her parents or my parents, now she's one that starts crying at the drop of a hat looking at an older patient, or not even a patient, but elderly person, or someone that she hears about that's on dialysis. She'll be like, I'll go help them if they don't have a ride. Like, she offers that extra step or that compassion because she learned it, but she learned it from the experience that she had. So she can identify with those type of situations. Not all of them. She doesn't understand all of them, but I'm saying, like, but that's a particular example of how she learned it through what life gave her. And that's something maybe life needed to give her to be able to evolve to a more compassionate type of a person. So that's just another addition.
Thank you. That's powerful. And I think you're not the weird, and it's not unusual. I think I talk to my patients, and when I say, I do say that I would pray for the patient and the family as well, based on the situation, condition, and where prayers are needed. And it's just so true. I think the essence of every religion is the same. And the essence, if we go to the deeper aspects, the spiritual aspects of every religion, it just boils down to the same thing, and we just are so interconnected, and I believe
Exactly.
we're also beings of love, is what I think. And leaving that along with I think similarly, I think when I walk into my patients where I have to pronounce, I do that time. I take time and just pray for that soul. So, and I think I'm doing that more visibly with my nurses as well these days. When I get when the nurses are in,
Yeah.
let's say, just let's take a moment and pray for the soul, especially if there's nobody around at that point. And sometimes I just be there to hold their hand when they're passing, and we know that they're passing, and that has happened a couple of times. So powerful, yes. And I think
Yes.
probably understanding the deeper aspects of our religions also will make us more. And I think probably that's where my journey and probably getting into the spiritual and philosophical aspects of life probably led me to this journey. So you're talking about trainable aspects, right? You said like compassion can be trained or compassion can be learned, right? So what is one thing that you would advise to our listeners that they could start doing today after listening to this podcast?
I think the biggest advice is just listen, and be in that moment. Sometimes you're listening, or your people are thinking you're listening, but you're actually listing what groceries you need to get after work, and you're thinking about, oh my God, I'm so hungry, I'm going to go eat lunch to right after this. But be in the moment. It's so hard to be in the moment nowadays. We have our phones with us. We have so many other things that can take our attention away. But if you're in that moment and you listen, so much things can be learned, so many things can be felt and heard. And I think that we've gone so much as a society away from that. And the other thing being touch. The power of touch we don't see anymore. We understand the power of text, of word, of things like that, but the power of touch is so powerful, and we're not there anymore, or we're going farther and far from it. AI is not going to take touch away, at least as far as I know. It's not going to be the same
Mhm.
despite whatever they try. I think that if those two combinations can bring so much learning to anyone. It doesn't matter whether you're in any fields, anything, or just in your everyday life with everyday interactions with individuals. Just those couple of things I think would be important.
Yes, that was something we could start doing. Do you have any other parting messages for our audience?
No, nothing else.
All right. Thank you, Dr. Kill. Thank you so much for taking your time. I know you're extremely active and on the go and have something happening in your life all the time. But thank you so much for taking time. And I enjoyed this conversation so much. Definitely more to go as well. And all the stories and your experiences and how we could still be active and be in the moment. And thank you. Thank you again.
Thank you for having me.